Tissue Integrity, Part 2, Introduction to Nursing Concepts, Martha Olson. The factors for the skin are many. We look at circulation problems with the diabetic or other circulatory issues not getting oxygen down to the extremities, and all of your wounds then will not heal. Many of your diabetics have gangrene and wind up with amputation of the toes or lower extremity as a result of that. Nutrition can be such things as your anorexic patient that is a diabetic with poor control, a cancer patient that has no appetite due to the chemo and radiation. Lifestyle is things like exercise that promotes circulation, good habits of taking care of the skin, knowledge of bathing and using tepid water instead of hot water that tends to dry the skin. We know that people that sit in hot tubs for long periods of time often do have skin issues because heat dries or pulls the moisture from the skin. A lot of people will tell you that they apply lotion to their extremities right after a bath or shower to help trap that moisture into the skin. And then your epidermis, we know that with the older adult, they often have very thin, fragile skin and have to cover it. If you've ever wondered why in the summer many of your older gentlemen wear long sleeve shirts, it's often to protect those arms. It seems like the arms have a lot of skin tears and they have a lot of issues with that. And the other condition of the epidermis would be your patient that takes steroids. Steroids are very drying to the skin, and no matter what somebody on high doses of steroids does, it seems like their skin continues to remain dry. In looking at the picture on page 1207 in Potter and Perry, these three types of incisions have the sutures to them. These are wounds that are primary intention because we made the incision with a sharp scalpel. The edges are approximated, or meaning they come nicely together without any gaping or loss of tissue. The third one, or the one furthest to the right with the dark, that is what's called a retention suture. Those would be used in your high-risk patient for evisceration or dehiscence as a result of either obesity because of the extra weight pulling on that tissue, your patient that is running a fever, because we know that sutures are intended to dissolve over time, but a patient that is running a fever will actually dissolve their sutures or their stitches faster and would be at high risk then for that opening up and not healing well. Accidental wounds, your abrasion is a scraping or rubbing. These are found on page 1190 in Potter and Perry. An abrasion hurts. It's like a rug burn that you would get, but it doesn't bleed. Usually heals very well without a lot of problems. Your laceration is greater than 2 inches long. It's about 1 inch deep and usually causes some serious bleeding. A laceration, we think of somebody that maybe puts their arm through a glass window and they have jagged edges to that. A poke is a puncture and it is a bleeder usually. If you have somebody that comes in with the nail or something in them, leave it in until the surgeon or physician looks at that, because that may be occluding them from bleeding because it's setting against the blood vessel. It's okay if somebody has a small puncture wound to let it bleed for just a little bit to flush the germs from that wound. And then your contusion is a blunt trauma type of injury with bruising under the skin that would be noted. A critical thinking, incision from surgery or an accidental wound, which one has a greater chance of infection? Hopefully we're able to identify your accidental wound, because our surgical should be a sterile environment and not contaminated. Our skin tear category 1 then looks like this. Another form of an accidental wound. As you can see, the discoloration to that lower extremity, as I talked about, from just below the knee, you see poor circulation and the discoloration of the skin as a result. Here is a skin tear with a flap. What I would comment about that is anytime you can get the skin to go back over the area that's open, it will heal a lot quicker than if you pull that skin epidermal flap off and it has to then heal that whole area to that. Our skin tear category 2 then is less than 25% of that flap has been lost, so there's scant tissue loss. You can see then that we have an open area, very thin skin, and that's going to take quite a while for that one to heal. A skin tear where there's more than 25% of the epidermal flap has been lost. On this person, it looks as though they have put a clear opsite over the top of that. It depends on the facility where you work or what the wound ostomy nurse is recommending for use of opsites. Some will tell you it traps the moisture down and they have more problems with infections. Others will tell you it traps the moisture down and it helps it to heal quicker. Our category 3 skin tear is a complete loss of the tissue, so it's an open area, and that is going to have to totally grow its own flap back and cover because that is gone. In response to that skin tear with the opsite use or without the use, I personally like to leave the skin open to air if it's a small area and clean it well and let it not harbor bacteria under that. But again, that is the call of the wound ostomy nurse or the policies and procedures of that facility. To help prevent skin tears, a lot of things we as nurses can do, a lot of things we as nurses can teach people how to do. With proper turning and lifting, that is not allowing that skin to get pulled when we are giving them a lift up in bed. So we want to lift and then get them up higher in bed instead of that shearing force that we have. Handle their extremities with care. If we take and pull off the IV dressing because we're removing the IV, we're going to take skin with that if we're not careful to remove that tape to the IV site carefully. Pad the rails of the bed or the wheelchair. If they accidentally hit that, that will cause a skin tear. Many of your older people, especially in long-term care, they will put like a stockinette or a sock like over that extremity to kind of help give it a little protection from any bumping or skin tears that could happen. Try to keep the skin moisturized and then keep everything out of the environment that might cause them to bump into or get a skin tear. Our treatment is to cleanse it with normal saline. Normal saline is non-toxic to the tissue. It's the same as what the body has, and so that is oftentimes what we use with the tissue to help clean it and keep it moist. Try to approximate or get that skin tear as closely aligned with how it should be so we have less tissue that's open, and then give it some wound care and secure it with a dressing. We need to document very carefully about that skin tear for several reasons. One is so we can tell, is it getting worse or is it, getting better? We also need to document so if they would be transferred to the long-term care or from the long-term care to the hospital, that we know what types of skin issues they have on admission because of the necessity to be sure that everybody is aware and take care of that. If your protocol allows, take photographs of it, but otherwise you want to give it a good description. It's superior to this, it's inferior, it's lateral, it's medial, it's this big, it's this color. And we will be in class doing some practicing of some of the different wounds and how we would go about documenting them. We will also in this unit be talking about the stages of a pressure ulcer formation, and our pressure ulcer or decubiti is a whole unit that we will be talking about. It's an accidental form of a wound, and they are staged 1, 2, 3, and 4, with 1 just being kind of a boggy area that we are watching and treating, because it will then open up to a stage 2. A stage 3, we're looking down into some of the subcu tissue, and a stage 4 ulcer is very concerning because we can actually see muscle and fascia and organs that are down below that, and that's a very deep type of a pressure ulcer that we hope that our patients do not experience. Our wounds then are classified as to their color. A red one is clean and looking ready to heal, and that's why we debride a wound, or we try to keep all of the eschar and dead tissue off of that area. Our yellow then has a layer of exudate or tissue, and then our black is that sloughing dark tissue that needs to be removed so that the healthy tissue underneath can then heal. As we look at the different contaminations to our wounds, a clean wound would be a surgical wound. The edges are nicely approximated. A clean but contaminated wound is one that has the potential to become infected. It's an intentional surgical wound, but we had to go into a non-sterile body cavity, and probably the picture is the best example. When we go into the bowel to do surgery, the bowel is full of E. coli and many other bacteria, and by opening up that colon, we then have a clean but contaminated. Part of what we do to prepare that bowel for surgery, if we have time, is to do the preps, the go lightly or the um, medications that cleanse the bowel for in preparation for that surgery. And then they usually give 3 doses of Ansef with that contaminated type of surgery just to prevent as a prophylactic. Our contaminated is an open traumatic, a break-in sterile technique, or infected, and so we know that that person is very high risk for an infection. And then our dirty infected is a traumatic injury or type that does have purulent drainage to it. So as we end part 2, we think about the types of skin tears that a person might have and what predisposes them, many of the factors noted in our skin assessment in going through our history and physical of that patient to identify that they are at high risk for a pressure ulcer decubiti formation, they are high risk for a skin tear, and then our different types of sutures we may see. It is part of the nursing interventions and in our scope of practice to remove the staples from a surgical wound as soon as the surgeon or the physician orders that we can do that. When you go to that wound with the sutures or staples, you want to look at the wound that it's approximated. Is there a color that we can document? Does there have any drainage to that wound? And then if they have staples, be sure to count them and document those with your daily charting. This ends part 2 of the tissue. Thank you.